Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to be discussing anti-inflammatory pharmacology, and we're going to be discussing two of the most major drug classes that exist in pharmacology, NSAIDs and steroids. Let's begin with NSAIDs. NSAID stands for non-steroidal anti-inflammatory drugs. The drugs in this class include ibuprofen, ketorolac, meloxicam, naproxen, indomethacin, and aspirin, plus a little bit more. Let's first break these six down. Three of these are over the counter, and three of these are by prescription. Aspirin, naproxen, and ibuprofen are all available over the counter, whereas ketorolac, meloxicam, and indomethacin are all behind the counter or by prescription only. So how do these work? The mechanism of action of NSAIDs is that they inhibit COX-1 and 2, cyclooxygenase 1 and 2. These are enzymes. These enzymes inhibit prostaglandins, which cause inflammation. Thereby, it reduces inflammation. Thereby, they are anti-inflammatory medications. One additional aspect of these medications is that they also reduce the development of the protective stomach lining. Because they reduce the development of the protective stomach lining becomes thinner and weaker, thereby making the patient more prone to develop an ulcer, which can lead to a GI bleed. Here's a breakdown of how that works. COX-1 supports the stomach lining, it supports the kidneys, platelet aggregation, and it promotes vasodilation. COX-2 is really where the essence of inflammation is. If you're wondering why we don't have a specific COX-2 inhibitor, we'll talk about that in just a minute. The indications for these medications is anytime you want to reduce inflammation, plus anytime you want analgesia, because these are pain relief medications, and anytime you want to reduce fever, which is antipyretic. Most of the time that we use this, it's for analgesia or anti-inflammatory. There's a lot of different anti-inflammatory things we could use this for, such as rheumatoid arthritis, gout, and so much more. There's obviously a lot of analgesic uses for it, such as headaches. Plus, we can also use it for a fever. That's probably more so in children. Keep in mind, ibuprofen, for example, in children is called Motrin versus the more common adult version is Advil. Those are both brand names, but the Motrin brand is targeted more towards children. The Advil brand is targeted more towards adults. Next, when a patient is taking aspirin, aspirin specifically can be used for platelet aggregation. You may have heard many times that patients take a baby aspirin every day, and that's to reduce their risk of developing a blood clot. And in that case, the medication is used for that additional aspect, which the other NSAIDs do not have, of causing that reduction in platelet aggregation. Only aspirin has that. Because of that issue of technically a risk of bleeding, this medication, specifically aspirin, again, should be stopped before any major surgery and before childbirth. All of the NSAIDs do have a black box warning that they can cause GI bleeding. That makes perfect sense when we explain that the lining of the stomach is supported by COX, and if we block COX, then the lining of the stomach won't be as well developed, and it will be weaker. It will be more prone to develop a peptic ulcer leading to a GI bleed. It also has a black box warning that it can cause adverse cardiac events. Next, the side effects. The number one side effect is going to be GI bleeding. That's obviously more an adverse effect, but that's definitely going to be the most tested on for nursing world is going to be the GI bleed. So what do you have to know as a nursing student for GI bleed? First of all, if the patient has any left upper quadrant pain, because that's where the stomach is, you have to be alert for that. If the patient develops any blood in their stool, you have to be alert for that. They may test you on an FOBT, which is a fecal occult blood test, and that would be considered an appropriate assessment to check for the side effects of an NSAID because of the GI bleed. Again, FOBT, it's one of the ways that we check for blood in the stool, and that would be appropriate to check for this adverse effect of GI bleeding. The whole class of NSAIDs are also nephrotoxic and hepatotoxic. If you've watched the pain video in the past, you know that we mentioned that acetaminophen is hepatotoxic, but it's not nephrotoxic. So most of the time when patients have a standard headache or something like that, they go into the local pharmacy and their choices are usually going to be ibuprofen or acetaminophen, Tylenol or Advil. Now, if the patient has a kidney issue, NSAIDs are nephrotoxic, so they would prefer to take acetaminophen. If the patient has liver issues, well, they're both hepatotoxic, so there's no indication in that regard to choose one over the other. Plus, an additional side effect is going to be tinnitus, specifically for aspirin. Aspirin is not to be used in children under the age of 18 due to the risk of Reyes syndrome. You're probably not familiar with that because it's become a really, really rare condition because we've gotten so good at educating the public that children cannot get aspirin. And finally, NSAIDs are available through multiple different routes with multiple different onsets. It's available IM, it's available PO, it's available rectal as well as some other routes. So it does have multiple different routes. Obviously, the vast majority of all time that we're giving a patient an NSAID, it's going to be the PO route. Now, NSAIDs are non-steroidal anti-inflammatory disease or drugs. In a minute, we're going to talk about steroidal anti-inflammatory drugs, more commonly known as steroids. But before we get there, let's look at one subset of different type of NSAID, and that is the COX-2 inhibitor. You'll remember a few minutes ago, I mentioned that NSAIDs are primarily used as anti-inflammatory drugs, and that primarily comes from inhibiting COX-2. We also mentioned that NSAIDs do inhibit both COX-1 and COX-2, and the COX-1 inhibition is where we end up with those risks of GI bleed and some other issues. So why don't we focus on COX-2 inhibitors? Well, we do. The drug is called celecoxib, and this one specifically inhibits COX-2. This inhibits the prostaglandins, which cause inflammation. So this is a great anti-inflammatory drug, and it is commonly used as an anti-inflammatory drug for diseases such as rheumatoid arthritis. However, this medication is not preferred over the standard NSAIDs for one specific reason. It has a major risk of adverse cardiac events. Okay, it does have less risk of GI bleed and some of the other stuff we mentioned, but it does have a major risk of adverse cardiac events, and therefore we don't want to use it excessively in patients. Obviously, the big exception to that is going to be rheumatoid arthritis. That's pretty much one of the only times that we have a patient chronically on celecoxib, and in that case, it's a risk versus reward and what's in the patient's best interest. But generally speaking, we don't like to use celecoxib. In fact, there used to be other COX-2 only inhibitors on the market, and all the rest of them have since gone off the market. This is the only one left, at least in the United States. Now let's move on to talking about steroids. For steroids, we have hydrocortisone, prednisone, methylprednisolone, dexamethasone, betamethasone, and there's so many more. How do these work? These work by having three distinct actions. One is that they suppress inflammation, and I did include in the parentheses how they suppress inflammation, but I think that's taking it even a step further that I don't think you're going to have to know at the RN level, maybe more at the NP or MD level. It does also suppress immune response, and it suppresses adrenal function. The suppressing adrenal function, it really does via negative feedback. And this one is important to know because if a patient is taking steroids more than 1 or 2 doses, they're always going to have to taper the drug down, which we're going to talk about in a minute. But I just wanted to point that out. So what do we use these drugs for? Well, basically, we use it for those three things: to suppress inflammation, to suppress the immune response, or to suppress adrenal function. The last one, suppressing adrenal function, we would do that in a patient that has adrenal cortical insufficiency or Addison's disease. We may also use it in inflammation, and that would be for the suppressing inflammation. We may also use it for immune suppression. And again, that would be based on the action of immune suppression. And finally, we do also use it for nausea. It's a little bit complex, and it's not fully understood how it works to help in nausea, but it does. We don't use it for everyday nausea. We use it more so for chemotherapy-related nausea. Now, we also use this for a bunch of inflammatory conditions, and since that's where we use most of this, I did put a list over here, a very small list, because this list could go on forever, but some specific things we use it for is gout, asthma, COVID-19, inflammatory bowel disease, allergies, cancer, and so much more. I see I put gout on there twice. I'll fix that. But the side effects and adverse effects, so let's move on to that. It does cause immunosuppression, so that's an adverse effect, that it can cause immunosuppression. It does also cause hyperglycemia, so make sure if the patient's already diabetic, they know that this might mess their sugar up some more. They might need their insulin adjusted, things like that. This can cause hypertension, again, so if the patient's already a hypertension patient or borderline, let them know that this might make things even worse. They might need to talk to their provider and get that addressed. This can cause osteoporosis, so this puts the patient at risk for bone density issues, and we'll talk in a few minutes about the education we need to do specifically about that. Other side effects are mood swings, weight gains, sodium and fluid retention, peptic ulcer disease, and abnormal fat deposits, and that's specifically for if it causes Cushing's, those abnormal fat deposits, things like mood face. Next, let's move on to a very important concept in steroids. We just listed an entire list of adverse effects of taking steroids, and this isn't even a full list. This is the basics, and this is what you need to know as an RN, but there are more to it. Based on this whole long list of adverse effects and side effects, this drug sounds like it sucks. And the truth is, this drug is a major issue with the amount of side effects it can cause. But we figured out, not we, I shouldn't take credit, but in pharmacology, we figured out a way around it. And that is to give this drug as locally as possible. And we have so many options to give this locally. We have hydrocortisone cream, that's a topical route. We have inhaled corticosteroids for asthma, that's the inhaled route. We have intranasal corticosteroids, that's Flonase, that's for flu-like symptoms. We have direct injections into the big toe for gout. We have so many options to avoid giving it systemically because, yes, this does have tons of major adverse effects and side effects, and we want to avoid it if at all possible. So we do have steroids available probably in more routes than any other drug, specifically for this reason, because we want to avoid this list of side effects. This list of side effects, by the way, as a nurse, you definitely need to know it because you're for sure going to be tested on it. Now, because it does have these major issues and because we have so many other routes available, we try to always use those if at all possible. If we don't have any other choice, then we go ahead and we give it systemically. That would be PO or IV. And at that point, we are going to end up with this full list of side effects, but then we've made the decision that that's in the patient's best interest. Steroids must always be tapered. And I said I would get back to this. Steroids suppress adrenal function. Why? The 2-second version is the fact that our adrenals produce steroids, adrenal corticotropic hormone. They produce steroids. And because they produce steroids, if we suddenly give the patient a ton of steroids, the adrenals say, hey, my job is done. There's tons of steroids here. I can go to sleep for a while. And if a patient gets, generally the rule is more than 1 or 2 doses of steroids, they must be tapered off of the steroids. Why? Because we need the adrenals to wake back up again and start producing the medication. Therefore, steroids always, always, always must be tapered. And this is where you have that standard terminology of a patient's getting a steroid taper pack or steroid dose pack, where they get, let's say, 40 milligrams on day 1 through 3, and then 30 milligrams on day 4 and 5, and so on and so forth until they taper down to 0. And this is the reason why, because of that negative feedback of the adrenals, the whole way it suppresses the adrenals is because we're giving so much to the adrenals say, my job here is done, I'm out. Next, this medication does have an increased risk of adverse effects, specifically GI bleed and peptic ulcer. If given with NSAIDs, we just mentioned a few minutes ago that NSAIDs has that risk of GI bleed. Giving this with NSAIDs could really make that even worse. We also mentioned this medication can cause long-term adverse effect of osteoporosis. Why? Because it decreases your bone density. Because of that, 2 things, and these are both fair game for a nursing test. One is any patient is taking long-term steroids, or if they're high risk, let's say a postmenopause female, even if they're taking short-term steroids, they should be encouraged to increase their intake of calcium and vitamin D, and that's as easy as getting a supplement off the shelf at Walgreens, Walmart, whatever. And additionally, the patient may need, if they're taking long-term steroids, they will need regular bone density scanning. That's a DEXA scan. Finally, because steroids do suppress the immune system, they are generally contraindicated in someone who has an active infection. I will tell you there are exceptions to that, but the textbook rule is going to be that if a patient has an active infection, let's say they have a fever, unless it's a post-transplant, that's a whole separate story. But otherwise, generally, if someone has a fever, we're going to avoid giving them a steroid because it's going to suppress our immune system. And we know when we have a fever, when we're sick, we need our immune system to help fight it off. That's the end of the anti-inflammatory section. I am going to throw in here the migraine medication of the serotonins and discuss migraines in general for just a few minutes, because I don't have another good place to put this. I looked at a bunch of different nursing books and nursing curriculums, and this is covered in a bunch of different places, sometimes in pain, sometimes in inflammation, sometimes in some catch-all miscellaneous section, but I'm going to cover it right here. So let's talk about migraines real quick. The first-line drug class for a patient having an acute migraine, the drug class is a serotonin 5-HT agonist. The classic drug here is sumatriptan, that's brand name Imitrex, and there are a few other ones, zolmitriptan and rizatriptan. These are all triptan medications. These are all the serotonin 5-HT agonists. The way these medications work is they cause cerebral vasoconstriction, and they decrease perivascular inflammation. I'm not going to get too deep into that. If you know that much, you're good on what the mechanism of action is at the RN level. What do we use this for? Its label use is for 2 things, acute cluster headaches and acute migraines. Now, one big thing that you need to educate the patient that they may experience when taking this is a feeling of chest pressure or chest fullness or chest heaviness. That's a really big deal to educate your patient, because if they weren't expecting that, they may think they're having a heart attack and cause their anxiety and all these other problems that make their migraine even worse. You also need to educate patients that they should take this as soon as they feel their migraine coming on. Most patients that develop migraines, they do feel it coming on pretty early. They should take this right away. Much better than trying to suck it up and wait until it's a full-blown migraine and then taking it. It doesn't work as well. Generally, for a patient having an acute migraine, this is the first-line medication. However, the guidelines do tell us that this cannot be taken more than 9 pills per month. So if a patient is given, let's say, 50 milligram pills or 100 milligram pills, they're going to be told to take that as soon as they experience a migraine. They may be told they can take a second dose an hour or two later if it doesn't go away. But generally, patients are limited to 9 pills per month, and that's in the guidelines. And if they need more than that, then we have to switch to a preventative strategy, which I'll talk about in just a minute. But for right now, we don't give a patient more than 9 pills per month, and that is because it can cause a rebound headache. If they're taking it more than that, if they're taking, let's say, 4 days in a row, they're taking it every day. Now on day 5, they're just automatically going to end up with a migraine because it's called a rebound headache at that point. Is this considered safe in pregnancy? That is a crappy question to ask here because I've literally seen some guidelines that say it is safe or relatively safe to take in pregnancy, and I've seen some guidelines that say it is completely contraindicated in pregnancy and teratogenic. I'm staying out of it. Generally, it is not recommended to be taken in pregnancy, but there are plenty of guidelines I've seen out there that do allow it to be taken in pregnancy, and I'm going to leave it at that. Next, this medication can cause serotonin syndrome. And this is a tricky question that nursing schools can ask because when we think of serotonin syndrome, if you've already taken mental health pharmacology or you watched our video on it, in mental health pharmacology, we have a whole bunch of drugs that cause serotonin syndrome, things like Prozac and Zoloft and all those other SSRIs and SNRIs can all cause serotonin medication. We don't think of it with a headache drug, but this one literally has serotonin in the name of the drug class. It's a serotonin 5-HT agonist, meaning it activates the effects of serotonin. So this medication can absolutely contribute to serotonin syndrome. If a patient is taking any other mental health medication plus serotonin 5-HT agonist, that is a problem, and you'd have to look into it. You'd also have to be reassessing any patient who's taking both of those medications for the risk of serotonin syndrome. Really quick, if you haven't already watched our mental health lecture, what is serotonin syndrome? It's where a patient has too high of a level of serotonin and they get a hyperactivation of a few different body systems. The signs and symptoms of this end up with agitation, confusion, fever, tachycardia, hypertension, hyperreflexia, and tremors. Next, this medication, serotonin 5-HT agonist, specifically sumatriptan, are completely contraindicated in patients with cardiac disease or uncontrolled hypertension. So if a patient does have uncontrolled hypertension, they cannot get this drug. Cardiac disease, that's a pretty vague catch-all of what is included in cardiac disease. And I left it that way on purpose because it does take a lot more getting into the details of what diseases they have, how severe it is, how well is it managed before saying that it's contraindicated. But this is what you're going to have to know from nursing school. Uncontrolled hypertension and cardiac disease are contraindications. If a patient does develop an overdose of this medication, they are going to end up with serotonin syndrome, and serotonin syndrome is treated with a beta blocker, officially known as a beta adrenergic antagonist. Now, I do want to spend just 1 second mentioning the fact that migraines in general are treated acutely. The first line drug is the serotonin 5-HT agonist. We do also have ergoalkaloids, such as ergotamine, which is another drug that we can use for an acute migraine. Plus, we have the CGRP receptor antagonist. The CGRP blockers are also used for acute migraines, but the first line is the serotonin 5-HT agonist, again, up to that limit of 9 pills per month. However, let's talk about that. If a patient is using more than 9 pills per month or needing more than 9 pills per month, we do at that point for sure recommend that the patient switch over to a preventative strategy while still keeping the option of having those acute pills ready for them. But a preventative strategy means that they're going to be on a medication every single day, hoping that instead of having 10 migraines a month, we get them down to 2 or 3 or ideally 0, but we get their migraine their frequency of migraines much more managed. What are the options that we have for migraine prevention? We have beta blockers, SNRIs, TCAs, anti-seizure medications, and again, the CGRP medications. Now, I do want to clarify, all of these medications are daily medications. So these medications would be if the patient is having migraines more than just 2 or 3 a month, where they just say, I'll just take a pill when it happens and I'll be fine. If it's becoming more than that, or even if those 2 or 3 per month, the patient makes the determination along with their provider that even 2 or 3 a month is terrible for me, I can't take it. I'd rather be on a preventative medication, take a pill every day, and just never have one. If that works out, that's a decision for the patient or provider to make, and that would be appropriate. If you have any questions, please reach out to Bullet Point Nursing. I hope you enjoyed our video. Please subscribe to our channel and like our content. Have a great day.